Hi everyone, we're just waiting a few minutes. Lots of people are jumping in at the moment, so we'll probably start in 1 or 2 minutes. Okay, I think we'll start. So firstly, thank you all for taking some time out of your lunch to join us today. For those of you who haven't been in one of these webinars before, we're doing a series of webinars. This is the second installment of what will continue to be a monthly webinar until we get through all of our templates. We currently have more than 130 templates on the portal. So most of you will be familiar with our portal. You just go to templates and you search those templates here. So today we're going through sesamoiditis, which can also be used for a fractured sesamoid. We'll go through heel spurs and talk about the slight differences between heel spurs where the pain is medial, central, and lateral, CMT, so Charcot-Marie-Tooth, and then also Achilles tendinopathy. So you can see here we've got 13 pages. Each page has 10 Orthotic recommended templates on it. So all you do is just go to this search function here and search. So sesamoiditis, it comes up with sesamoiditis and low profile. I added 3 yesterday, so we'll just keep adding them. If people bring to my attention that there isn't one there, then we'll add that for you. And they're really designed to give experienced podiatrists new ideas and new grads and less experienced podiatrists lots of new ideas. And you can just you can clone them and make them your own. You can change them. You can use them as is. You can open them and make slight changes. But we also don't want you using them blindly. So for those of you who aren't aware, there's a little question mark up here. You can just click on that, scroll down to template descriptions, and what you'll get is a list of all the templates. Excuse me, you can search for them or click on hallux rigidus, for example, and it'll be a 2-minute video explaining why we're selecting certain things, and then feel free to change those. So we'll get straight into it and start talking about sesamoiditis. So in order to use the templates, you click on the template number there. It's a little bit faster to use our internal portal. So I'm just going to use our internal portal. So sesamoiditis, we'll touch on low profile in a moment. So click on the template number. You can clone it or use it. I'm going to edit it just because it gets me in there nice and quickly. With most of our templates, it's very difficult for me to determine the rear foot correction and the exact design. So the design comes into play with certain conditions. If you've got a medially deviated subtalar joint axis, then we're going to be using one of the rear foot devices. In this condition, we're using the mod root. The amount of rear foot correction comes down to supination resistance, Jack's test, various other factors. So you'll most likely need to alter those, but these are the most common rear foot correction and designs used for this condition. So the reason we've selected the mod root is it's the most distally controlling. So you'll see as I go to the part first ray fill, we start to wipe away underneath the first ray, and the full first ray fill, we completely get rid of it altogether. The reason we're selecting the mod route is because it actually elevates the first metatarsal and starts to take pressure off the sesamoids. Now, something to consider with that is that that's good for sesamoiditis, fractured sesamoids. We're taking the pressure off the first MPJ. However, you are also dorsiflexing the first ray a little bit in this orthotic, and that may not be better for that patient long term after they've recovered from this pathology. So you may want to consider doing a part first ray fill for longevity and for use once the sesamoiditis has resolved. However, for this template, the reason we're doing it is because we want to elevate the first ray to take the pressure off the first metatarsal. It's also why we have a higher arch, because we want to create contact with that first metatarsal, start to lift it off the ground and take that plantar pressure or dorsal grade force from ground reaction off the first metatarsal head and sesamoids. So that's the theory behind why we've chosen that design and a higher arch. We don't need a whole lot of other intrinsic modifications. You can do like a medial heel scribe if you want to create a little bit more calcaneal inversion to take pressure off the first. One thing we've selected here is a first MPJ cutout. So the theory being that we lift the first metatarsal, not metatarsal head, and then, and then create a first MPJ cutout. So for those of you who aren't aware, if you're not exactly sure what the first MPJ cutout is, you can click on that question mark, go down and click on here. So all we're doing is removing the corner of the medial anterior corner of the orthotic and allowing an additional space for that first metatarsal head or sesamoids to sit in. Shell material, again, there's no specific reason to choose PolyX or 3D print. For those who want more information, you can click here. You can look at rebound and compression rates. The PA11 is a little bit harder to flex and it rebounds a little bit faster. PolyX is a little bit easier to flex and a little bit slower to rebound, so it's better if you're trying to decelerate pronation. But I won't go too much into that because we've got a fair bit to get through, but that information is there for you. And then what becomes important is this single wing PMP. And the most common material is poron and 6.4 mil poron. And that becomes important if you have lesser met head issues. So if you're dealing with a plantar plate tear or a nerve impingement or fat pad atrophy or something like that, because as the patient stands on that, it probably compresses by about 50%. So you're getting an effective 3 mil single wing PMP. So what we're doing with the single wing PMP, and you can go in here and have a look at them, is it's like a reverse Morton's extension. So we're supporting met heads 2 through 5, but we're also creating a support for the first metatarsal itself. So again, we're dorsiflexing the first metatarsal, taking the sesamoids off the ground, and we're creating this deflection for the first metatarsal head. So if you were to do a mod route with a part first ray fill because you want to have that first ray function after the sesamoids have healed, then you may go for that and just have a larger or a thicker single wing PMP. So it is more beneficial than a reverse Morton's because it supports the first metatarsal without supporting the first metatarsal head. And then the last thing, the covers are up to you. Obviously, a bit of cushioning, medium or soft EVA certainly helps with the offloading of the pain on the first metatarsal. We've got a question. I'll come to that in a minute. The last thing that may complement this prescription is a carbon fiber spring plate. So the spring plates aid in propulsion. They stiffen up the shoe a little bit, but also the tapered carbon fiber spring plates have a little toe spring in them, and it just helps propel during gait. And so if you've got one of the diagnosis packs with those, you can instantly try that chair side with the patient. If they get some relief with that, then it may complement the orthotic. All the carbon fibre spring plates are under 1 millimetre thick, so they are designed to sit underneath a full-length orthotic. So let me just go to... Oh, okay. Sorry, there isn't a question. Tegan was just talking to me. If you want to post questions, I might get to them at the very end. So for those people that have only got half an hour that may want to hear the 4 conditions, and then I'll answer questions a little bit later. Okay, so I'll quickly go back to the low profile. So Sesamoiditis low profile. All we're doing is trying to get it into a slimmer shoe. So the way in which we can do that is to reduce the arch height a little bit. So stay with the mod root, but just reduce the arch height, which will debulk the orthotic. Use an intrinsic met dome instead of an extrinsic one if you want to have a met dome. So that met dome can help support the transverse arch and allow that first MPJ to offload. And the other thing, 6 mil heel cups. So we've reduced the heel cups, which reduce the depth. Medial heel post. And then the single wing P&P, we've changed from a 6 mil poron down to a firm 3 mil EVA. So using a firm 3 mil EVA, you're getting about the same effective height as a 6.4 mil poron. What you are losing in that is the cushioning. So if you've got those lesser met head issues or fat pad atrophy and need a little bit of cushioning, that may not be beneficial, but it may be your best option if they're wearing inappropriate shoes. So if you've got any questions on that, feel free to post them and I'll answer them. Otherwise, I'm trying to keep these sessions to half an hour. And so I'll move on to the next one, which is our heel spurs. So we did plantar fasciopathy and plantar fasciitis last month, and that's online in the news and booking sections if you want to watch that webinar. So I'll go through, so where it says medial, we're talking about that pain being on the medial anterior calcaneus beneath the calcaneal tubercle. So click in here. And we're trying to offload the same forces as we're trying to offload with plantar fasciitis. So what we're trying to do there is decrease the compression forces. So the compression forces are when you make contact with the ground, as well as those tensile forces, which, you know, when you sort of pronate, the foot elongates, you get that stretching of the plantar fasciitis, which can be sort of a precursor to those heel spurs. So the way in which we decrease those tensile forces is by inverting the rear foot and then everting the forefoot. So as we get down a little bit further, you'll see a forefoot valgus. So by inverting the rear foot, everting the forefoot, you shorten the distance between the metatarsal heads and the calcaneus. We've moved into a moderate root first ray fill. There's no point in utilising a forefoot valgus with a mod root because all you're doing is trying to transfer weight from the lateral side of the foot to the medial side of the foot, and then you're trying to stop it with the mod root. So you need to start to enter a design where we're taking contact away from that first ray and allowing it to drop. So again, no other necessary intrinsic modifications here. We do look at a first MPJ cutout. Again, when you're adding that valgus, it doesn't hurt to have the first MPJ cutout to allow those tensile forces, to address those tensile forces, in shortening the distance between the metatarsal heads and the heel. Heel spur accommodation, and I'll get to that as we get a little bit further down. Essentially, what that is just a hole in the center of the orthotic, and we fill it with poron. So what we're trying to do is cushion that tender area where the heel spur is, but that tender area can change. It can be medial, lateral, or central. So as we get down a little bit further, we've got full heel posts, we've got our forefoot valgus to sulcus out of a firm EVA because we're trying to get a directional change. But the thing I want to talk about here is the second edition, which is our J-pad with the heel spur. So J-pad is a version of a horseshoe pad. Sorry. Problem with the horseshoe pad we found over the years is that you create a horseshoe pad in order to lift the calcaneus off the shell of the orthotic and allow, and it starts to deal with those compression forces. The problem we were finding is that medial side, when you've got medial pain, could often dig into the tender area. So we modified it to call it a J-pad, and we really don't do many horseshoes anymore. The majority of them are J-pads. So it still lifts the heel off the orthotic, allows some compression and some softness before you get onto the shell. And you can either have that with or without a heel spur accommodation. So that's what it looks like without, and that's what it looks like with. And the key to these three different scripts, medial, central, and lateral, is moving this heel spur accommodation. So we're dealing with the pain on the medial side in this script. So we've added some additional poron. We've added an EVA as a top cover. You may want to choose neoprene if you prefer that. But if you've got room in the shoe, some sort of cushioning top cover, or even going to a soft top cover in 2 or 3 mil may be more beneficial. But then I'll put here heel spur accommodation to sit in the medial anterior corner of the heel post underneath the medial calcaneal tubercle. So again, going back to this picture with the J-pad, all we'd be doing is moving it from where it is here into that corner there and creating that soft spot beneath the tender area of the foot. So, and really the only difference between that and the heel spur where the pain is medial, central, everything remains the same. Except for the notes. So what it's saying is to sit in the center of the heel post, which is essentially what it's going to be like in that picture. But we don't tend to recommend the J-pad when the pain is lateral. Oh, heel pain, heel spur. When it's lateral, what we'll be recommending is just a heel cushion, so a poron heel cushion. So everything else remains the same. Get down here, and I haven't added it. So, oh, hang on, no, sorry, I've added it in the addition type. So got a forefoot valgus if that suits, and then you've got a poron heel cushion. These are set up as bilateral. Obviously, if it's only left-sided, you take away the right. So you got poron 3.2. You may want to go 6.4. You may want to go for a slow release poron. The XRD poron is actually a little bit firmer. It's more for shock absorption. So I'd probably recommend the medical blue poron or the red slow release poron, depending on what you want to do. But I've set the template up to be 3 mil poron, just a general cushion across the heel. You may want to consider with this increasing the heel cup depth. So it's currently at 12. If you go to like a 6 mil or 6.4 mil heel cushion, you may want to increase that to 18 mil just to give yourself a little bit more room within that heel cup to add that cushioning. Got any questions, Tegan? Or we? No? Okay. All right, so in the next 10 minutes, I'm going to try and get through CMT and Achilles tendinopathy. So you can either put in Charcot-Marie-Tooth or CMT. We've got abbreviations. We've got CMT for a semi-custom. So if you have brackets there, CS, but you've also got it over here, semi-custom. So obviously with CMT, it changes over time. And so it's hard to have a, one script fits all. You are dealing with your higher arches, your curl toes, your sometimes drop foot, inverted calc. So I've put in here as more of a note for you is, and I've recommended an as-is. So with an as-is, we're going to follow the contours of the foot in the position in which you cast it. So if you've cast it in a slight varus or valgus position, then we're going to follow that contour. We can do an as-is device with a valgus correction or with a varus correction. So if they're starting to get more of that inverted foot, you might want to do an as-is, but add a 5-degree valgus correction to that to try and prevent those issues that develop later on with this condition. So that's really something that you will need to determine. If you want to talk about it, feel free to call Orthotic and we can chat through it. As is device, or you can choose other and go to an accommodative device, but we've chosen as is for this, keeping the arches nice and close to the foot, keeping in mind that some of the arches in a CMT can get quite large and take up a lot of room in the shoe, so you may need to reduce that down. As with most cavoid type feet or supinated feet, we tend to add a little bit more lateral heel expansion. So the standard is 5. We tend to add a little bit more for various reasons. You can look into some of Josh Burns's research and stuff like that to see why that's recommended. Whether you have a lateral cast grind, again, is up to you, but you may want to consider increasing that lateral column if you need more of that lateral support for this condition. Sometimes a met dome or a first MPJ cutout are beneficial. Again, sometimes you get that plantar flex first ray dropping down, can be rigid. So we tend to give it the space it needs to sit slightly dropped. I've leaned towards Poly-X because of its compression and rebound rates. It's a little bit softer, a little bit more forgiving than your PA11, and certainly less bulky than your EVAs. So you're getting a sort of a low bulk orthotic that isn't too rigid. You could consider a half lateral post. We've got a full post on it, but you could consider a half lateral post if need be. Again, a met tone for this foot type doesn't hurt. And then a couple of things in the notes that I've added, things to consider. So, leaving the cover off if you're interested in using what we refer to as a buttress. I'm just going to stop sharing so I can make sure I can see my screen. So this is what we call a tear-shaped buttress. So you get the sort of clawing of the toes, and this sort of sits between the metatarsal heads and the toes. And buttress being a supporting sort of structure, it aids to prevent those toes from continuing to retract. So it just sort of holds them in that position. The reason we recommend leaving the cover off is it's quite difficult, regardless of the scan, for us to get these exactly in the right position for that person's foot. So this is a 6.4 mil pour-on buttress, but you would need to place it on the foot, and the best way to do that is before you put the covers on. So that's something to consider. If you're not interested in that, just feel free to delete that section out of the notes. It gets quite confusing if you leave that in there and don't want it. And the other thing that may help, again, is your carbon fiber spring plate. So, you can get people that are sort of got that difficulty walking and difficulty lifting their foot. And so this stiffens up the shoe, may aid in propulsion. Again, getting back to that diagnosis pack that I think most clinics should have. It's a matter of getting them to try that before anything else. And if that aids with their propulsion and gait and they feel comfortable, then it's a relatively inexpensive adjunct to this type of orthotic. So that's it for CMT. Again, there's going to be significant variations given the various conditions of it. So feel free to give us a call to talk a little bit more about that. So we're trying to do this between 12:30 and 1, which gives me about 5 minutes to do Achilles tendinopathy. So Achilles tendinopathy, let me open it. So once again, the design of the orthotic and the rear foot is going to be based on your assessment, supination resistance, Jack's test, medially deviated subtalar joint axes, etc. Again, I've gone for our most common midfoot controlling device, which is our part first rate build, because it allows for some first rate function and some first rate plantar flexion. And then we start to deal with the forces on the Achilles. So we're dealing with the sort of contraction forces of the soleus and the gastrocnemius in order to lift the heel off the ground, if you like. But we also want to consider the inversion eversion forces and the sort of slight bending of the Achilles that happens during gait. So a lot of people are going to heel strike slightly laterally in that, slightly inverted position, and they're going to end up in that somewhat pronated position. So trying to prevent that medial and lateral bending of the Achilles tends to work quite well. And dealing with the sort of contraction forces is a matter of elevating that heel via a temporary heel raise. So in order to deal with that inversion eversion forces, we're getting back to that rear foot varus correction along with forefoot valgus. So part of this script looks very similar to the first part of your heel spur or your plantar fasciitis. You want the first rate function. We're inverting the rear foot. Again, these things may or may not be relevant to the individual patient, and you can always add them in. Oops, I haven't added the material. I'd probably go more for a composite if this person is a one-directional athlete, like a sprinter, a runner, a distance runner. General exercise, probably poly. It's got that. It's a little bit more forgiving and has a little bit more flex, and then maybe 3D print for someone that isn't overly active. Sorry, I haven't. I tend to also just go 3mm poly or 3mm PA11 or 3D print. Obviously, you need to adjust that, and you can click on these and look at various weight categories, although weight isn't the only thing to consider. There's amount of pronation, there's activity, but I won't go too much into how to choose that at the moment. Rear foot post is normal. Now, we've added an 8mm heel lift, which is sort of pushing the upper limits of what can fit in most shoes. Feel free to increase or decrease that. And we've done the heel post out of the shell material, but I've done the heel lifts out of EVA. So no other addition types. Oh, hang on. Sorry. I haven't finished this script. I would be adding a forefoot valgus to sulcus. And this is how quickly it takes us to add our template. So again, out of a firm material, because we're trying to get a directional change, I'd be adding forefoot valgus to deal with that inversion. And then getting down to the notes, it's like I haven't saved this. All right, so I'd be doing heel raises out 350 density EVA. And the reason we're doing it out of EVA is so that you can remove it at a later date when you need to. We can do an 8mm heel raise out of PA11. If you've ever tried to grind that off, you'll be there forever trying to grind an 8mm heel raise off a 3D printed PA11 orthotic. The Poly X is a little bit softer and is easier to grind, but it still will take you a while. So we generally add the heel raise out of EVA. So I'm just going to submit that so that it's in there. And so I had someone yesterday ring me and say, "Oh, have you got a template for rheumatoid arthritis?" And I didn't. And so I just jumped on there and created one. So now if you is it on there? Rheumatoid arthritis there. So it doesn't take us long to create, and it was the 184th template that we've created. So it doesn't take us long to make them. Just a reminder that you guys can either take our templates, and I'm going to jump back into your the client-facing portal. You guys can just grab any template and say, yep, I like 80% of what you're doing, but I don't like some of it. You can go clone template. You can give it a name, continue, and that becomes your template. And with your templates, only you can create them. So I know there's someone called Amy in this client portal, and they're just test ones. So anyone within your portal can see the templates that you create, and you can publish them or unpublish them for the people that have access to your portal. No one else in the broader community can see your templates. However, everyone has access to the Orthotic templates. So, okay, so I've done that in 30 minutes, which is so yeah, okay. All right, so I'll jump into Q&A now. So CMT prescription, rather than the additional carbon fiber spring plate to the orthotic, can it be incorporated as a carbon fiber orthotic? So the answer is yes, but you need to do a carbon composite orthotic, make a full-length carbon composite orthotic. So carbon composite is it's a composite material. It's part polypropylene and part carbon fiber, and that is our composite, our XT material. The only slight disadvantage is that because it's a mixture of polypropylene and carbon fiber, is it's slightly thicker. So you're looking at a 2.7 or 3 mil 4-foot thickness, whereas the pure carbon fibers are under a millimeter. But you can't mold the pure carbon fibers. They're too rigid. So yeah, to answer your question, yes, you can do it. It's just done out of a slightly different material, the carbon composite. Is there any other questions? I know I get through that pretty quickly, but the whole point of these monthly sessions are to try and be time efficient for you guys. Take half an hour lunch break, get some good information, and then tap out, as opposed to sitting here for an hour or 2 hours. So if there's any other questions that you don't want to post here, then feel free to send an email through and ask. Otherwise, at some point, we'll make this webinar available for you to review it on the portal as well. All right. Thank you very much for giving up your time, guys.